Hey everyone, thanks for joining me for our third part of the anterior approach total hip replacement series. We'll be talking about the anterior approach today and also the implants that we use. And so we'll be covering all the different ways that there are to do a hip replacement, all the different approaches, and then touching on some of the basics of the implants that we put in. So when it comes to surgical approaches for hip replacement, there's a bunch of different ways to get into the hip joint. The one that I use and the one that I think I can get the best results with is called the anterior approach. And anterior means from the front. So we make an incision in the front part of the hip to do the hip replacement. I've listed the other options here just so that if you guys have heard of these, you know what they are. There's anterior lateral, which is a slight variation on the anterior approach. You can go directly lateral. Lateral means from the side. Some people like to do what's called a superior approach, where they go in from the top of the hip. And then the most common approach worldwide is called the posterior lateral or the posterior approach. And that's the approach where you go in from the backside of the hip. And one of the main reasons that I like the anterior approach is because I'm able to get into the hip joint without cutting any of the muscles. There's a plane in between the muscles that I can go through, and we just basically pull the muscles to the side, give them a little bit of a stretch, and we can access the hip joint. The posterior approach, you have to actually cut through the gluteus maximus muscle, which is a large muscle that you sit on, and stitch it back up. And so I think there are definitely some advantages having to cut any of the muscles to do the hip replacement surgery. There's some other advantages to the anterior approach that we'll get to in the future slides. This is what the incision looks like. And so this is a person on the left part of the screen that's laying on their back on the operating room table. And we draw a couple of the landmarks on the pelvis so we know exactly where to make that incision. And this is a different person back in the office. And you can see that it's not the smallest incision. It's not the biggest incision. It's usually covered by your clothing. And what I tell patients is that if you're a size 2, you get a size 2 incision. And if you're a size 10, you get a size 10 incision. It varies just based on the size of the person. The most important thing is that we can see the anatomy so that I can safely do the hip replacement surgery. These are some of the main benefits, as I see it, to the anterior approach. As I already said, you don't cut any muscles. You just pull them to the side. And you don't have to go through any nerve fields either, meaning you don't have to cut any of the crossing nerves. On one side is one nerve, and on the other side is another nerve. So you don't really run the risk of damaging crossing nerves, which is really nice. And there have been a lot of people that have looked into anterior approach versus posterior approach. The anterior approach has really become more popular in recent years. And so when people compare these two approaches, they have found that there are some advantages to the anterior approach, even over large populations and a bunch of different surgeons doing the operations. And most of those have to do with early recovery, in that patients have, in general, less pain right after surgery, and they get up and get going sooner than people with a posterior approach. In the end, most people end up about the same, but on the front side of things, seem to do a little bit better with the anterior approach. The second really important benefit to me is the anterior approach allows me to put the components exactly where I want them. And one of the advantages of doing an approach from the front is that the patient's laying on their back. And during the operation, I use an x-ray machine that I'm able to bring right above the patient, take an x-ray, move it out of the way. And based on that x-ray, I can see exactly where the parts are. And the two parts are the cup on the pelvis side and then the stem inside the femur. And I can see exactly where those parts are during the operation. So I know exactly where they are before we leave the operating room. And it gives me the opportunity to make changes while my patient's still asleep, so I can really dial in the position of those components. And that does a couple of things for you as a patient. Number one, having the parts in the right position means they'll last the longest that they possibly can. And secondly, one of the complications that we talked about in one of the earlier discussions was dislocation. And we know that if you put the components in a suboptimal position, your chance of having a dislocation is higher. So ensuring that I put those parts exactly where I want them means they'll last longer and you'll have a better outcome. And then finally, patients like it. And I think it's the summation of all of these different benefits that patients like the anterior approach. And at our location, we do the anterior approach. We use a portable x-ray machine at the time of surgery. I even use advanced technology to help me know exactly where those components are, and to the point where there's a computer program that looks at that x-ray during the time of surgery and tells me exactly how much I've changed the leg length or the offset or the cup position. So I can really dial it in to get it exactly where I want to have it. And so I think what matters most when you're talking about approach, it's not really the size of the incision. I don't think that anyone's ever shown that patients have better outcomes. They may like the way the incision looks better, but again, the incision is just our way of accessing the joint to get the parts exactly where they need to be. That's what's most important. I think getting patients up and getting them moving right after surgery is really important. So, same day of surgery, we have patients up and standing and walking on their hip replacements. They're up out of bed multiple times, going to the restroom, walking around the ward, working with physical therapy. And so I think that that early mobilization teaches the body that, hey, I can trust this thing, it'll support me, and I get up and get going. And then the third really important thing I think about approach is this multimodal pain management. And what that means is that you're not just getting a bunch of narcotic medicines and just kind of laying there um, all drugged up. You know, we inject a bunch of numbing medicine all throughout the surgical field at the time of the operation, deep down in there where I'm making the cuts on the bone and doing all the work, all the way up to the skin. So the whole surgical field gets injected with both numbing medicine and anti-inflammation medicine. And that really helps people for the first 24, 36 hours. You know, they wake up and not really having very much pain, which is fantastic. That allows us to limit the number of narcotics and the amount of narcotics that patients are getting. So that makes your mental status more normal, and it just helps with your recovery to be even faster. And then finally, something as simple as putting ice on the soft tissues. That ice cools the soft tissues, decreases the inflammation, and helps you feel better. So there's all of these different things that we do to limit the amount of narcotics that people use to get you up, get you moving, and get going as soon as possible. I think that's what matters most. And from an anterior approach, I think I'm able to do all of these things and hit all of the objectives. So in my hands, that's why I like to use an anterior approach. This is a picture of a model laying on this fancy table that we use to do this approach. This is called a HANA table. And you really do get these ski boots put on your feet, and it's locked into the table with all these fancy pulleys and rods and ways to move the legs into different positions. And this is a really, really important part of the hip replacement surgery that I do, because what this allows me to do is to get access to that hip joint through a pretty small incision and not cutting any of the muscles. So I have a whole team of people that helps with this operation. It's not just me and Shane, the physician's assistant. There's a surgical tech that hands us instruments. There's a circulating nurse that positions the leg in all of these different positions. And we have a bunch of different commands that we use so that we know how to do it safely. We've got the reps around that are getting the parts for us. I mean, there's a whole team of people, the anesthesia doctor, everybody working together to get you through this. And we use some of this fancy technology like these tables here to help us do the operation. So here's a peek inside the operating room. On one of my future series episodes, we're going to actually go into the operating room and I'll show you some of this stuff. But what we have here on the left screen is a patient laying on their back. The blue drapes are the sterile drapes that we put on. That machine that's sort of C-shaped, it's got a big head on top of it. That's the x-ray machine. And just to the side of that are the x-ray images that we see. We actually get some x-rays before we even cut the skin as part of our planning. Those are obviously the surgical lights above, but that's that fancy table that my patient is laying on. And then on the right, that's our scrub tech who's putting the final drapes on as we're getting ready for surgery. And this is what it looks like when we are ready to do the operation. Everything's draped out and it's nice and sterile. We've got a little window there that we operate through. That C-arm that's right on the other side of the patient takes the x-rays. We'll get a sterile covering on it, and that's the x-ray machine with the monitors there to show us the hip replacement. And again, with that C-arm and with that x-ray machine, I know exactly where the parts are before I ever leave the operating room, which gives us a really good sense of confidence that we've done just as perfect of a job as we possibly can. So here's a couple of pictures of, these are just very basic pictures of what it looks like to do a hip replacement. And on the top left picture, that's an actual look at a patient's hip socket. And that thing in the middle is called a reamer. It's basically like a cheese grater that spins around to prepare that socket so we can get the cup in it. And that top right picture, that white plastic that's sitting inside of the cup. And then on the bottom are the two x-ray images during the operation. The one on the left shows the reamer actually going in, and then that's what the cup looks like once we put it in there. So again, we know exactly, we can see what we're doing in the real world, and then we can also take a picture of it with an x-ray machine and know exactly where those parts are. So that's what we call the acetabular or the cup preparation. And then for the femoral exposure, the other part of the hip replacement, just a couple of basic pictures here showing in the top left that we actually have this hook that goes around the femur to elevate the leg up. And in the middle picture there is our circulating nurse who's putting the leg down and over. And we use these fancy instruments in the top right picture there to make sure that we're doing it safely and we're putting the part appropriately down inside the femur, and we prepare that femur bone for the stem. And we can actually see it in those bottom left and bottom right pictures before and after we put the stem in. So in one of our future episodes, I'll show you some of these instruments and how they work in more detail. But just know that there's a lot of moving parts going on to do one of these hip replacements. And then this is that intraoperative technology that I was telling you about. And this is an x-ray on a computer screen, and Joint Point is the technology that I like to use. And what this does is it takes your patient's anatomy and different landmarks, and it actually overlays a picture before the operation and then during the operation. It puts them over each other. And so I can tell exactly, have I lengthened the leg? Have I shortened the leg? Have we made it stick out farther or closer? And are those parts exactly where we want them to be? It tells us all of those different measurements and allows me to make changes with the trial parts before I put the final parts in. So really powerful technology that we utilize to get your hip replacement just as perfect as we possibly can. And so, the question that I hear from time to time is, why doesn't everyone do this if it's so great? And I just go to this picture here of an x-ray, and what you can see is this is one that we've gotten from the library of Anterior approach, where someone did a hip replacement and they didn't get the stem where they wanted it. It's not actually in the bone. And so we circulate this picture around as we teach at our Anterior approach hip replacement courses, as just like, hey, there is a learning curve associated with this. And I think that's why a lot of people don't do it, why it hasn't been uniformly adopted, because you've been doing it for a posterior approach for 10, 20, 30 years, and then you got to switch over and do it a completely different way. And I think that people do a really nice job from those other approaches. And if that's what they're comfortable with, then that's perfect for them. But some of us coming up in this sort of next generation of hip replacement doctors, I learned how to do it both ways, and I found that I'm better and I like the anterior approach better. So that's why I like to do it. But there is definitely a learning curve with this, and things like you just can't see well enough. You don't know how to use the table properly. You're not quite comfortable with the releases, and so that can cause you to put the stem out the bone like this person did, or get a fracture, which means a break in the bone. Or some people just don't like investing the time to learn. It takes longer when you're first learning. So there's also special instruments that you have to use, and the special table. And that table's not free, just like anything in this world, right? The table's not free. And so there's a bunch of different reasons why people don't all do this. And I actually think that using an x-ray machine during the operation is a powerful tool for me, makes me a better surgeon. Some people don't like getting exposed to that radiation. You're doing hundreds and hundreds of these a year over the course of a career. That can add up. So I actually wear a full lead jacket, thyroid shield, skirt at the time of surgery. Pretty uncomfortable, pretty heavy, gets you all sweaty. So it's just, some of this is surgeon personal preference too. But when I put all the factors together, for me, in my hands, anterior approach, I think I'm a better surgeon that way, and I get better outcomes for my patients. So I wanted to show you this study. This was done by Dr. Barrett, who was my mentor here at ProAlliance. And he actually was one of the people that did the randomized study comparing the anterior lateral, or the anterior to the posterior lateral approach. So the traditional kind of going in from the back versus the anterior approach. And he found less pain, better mobility for the first 3 months after surgery, and really no difference at 6 months and a year. And, I would say that I personally currently perform 98% of my hip replacements going from the front. There are a few extenuating circumstances where you don't want to be in the front part of the hip. And so maybe 2% of the time we'll do a posterior approach. But, because of data like Dr. Barrett's and our experience here, we go from the front, and I think it's great. And again, less pain, shorter hospital stay, better function for that first 3 months, earlier return to work, better component position for me, lower dislocation rate. That's actually been proven in the literature multiple times. And then fewer postoperative restrictions. You don't have to worry as much about the position that you get your leg in, because the chances of that hip dislocating are lower because you haven't cut any of the big muscles around the hip. So a bunch of advantages for the anterior approach. And the other thing that I would share with you guys is that we're getting so good with the pain control aspect of this and getting people up and moving that some of our healthier patients are going to get to have these surgeries done as same-day surgeries, even starting this fall. So we're actually constructing a new center where we can do our hip and knee replacements as same-day surgery. So we could even save patients a hospital stay. And we'll talk about this more in some future episodes, but what better time to get out of the hospital than with all this COVID stuff going on? And so we're really excited about that coming through. So now the second part of the talk, talking about the implants. And so I put, implants are kind of like cars. So I explain this to patients. There's a bunch of different kinds, right? BMWs, Ferraris, Fords, Lexus, Nissan. There's a bunch of different types, and they'll get you where you want to go most of the time. It's just sort of personal preference. And there's a lot of surgeon preference that comes into what implants you use. There's really three major companies: DePuy Synthes, Smith & Nephew, and Zimmer Biomet. At our institution, we use DePuy Synthes products. I think it's the best stuff out there, and that's why I use it. It's got great data to support how long it lasts. I'll go over a little bit of that with you. But people often ask, what company makes the parts that I get. And to be honest with you, most of these major companies make great products, and it's really kind of surgeon preference. But these are the three stems that I like to use the most. And the stem is the part that goes into the femur bone, okay? And they're called actus, Karai, and Summit. I would say Karai, that middle one, is the one that I put in most commonly. And then second most commonly would be the Actus one. And then third most commonly is the Summit. And these parts actually have a coating on them that the bone grows into. So I brought one here. This is an actual hip replacement stem. And what's cool is if you come into the office and we have a visit about this, we have these parts here and you can hold them in your hand and you can feel them and feel the weight to them. But I wanted to show this particular one just to show this rough coating that's on it. That's been designed over decades of technology and advancements to be the optimum surface for bone to grow into. It's rough, but it's just the perfect amount of how rough it is that bone cells grow into that. So in the vast majority of hip replacements, we don't use any cement. We just actually prepare the bone perfectly and for the stem within a millimeter, and it press fits in there and the bone grows into it. That Summit stem that's listed there is the one that we use if we have to cement. There are occasions where maybe the patient's bone isn't quite strong enough, or they're a bit on the elderly side and we're worried about the bone's ability to grow in, that we will cement them in. So we can do it both ways, and you can do it both ways from an anterior approach. But these are the three most common stems that we use in DePuy Synthes products here. And you should know that it's not as simple as, okay, well, open up the stem and put it in. There are so many different iterations on this stem and so many different variables. So that little picture, that little diagram on the left side of the screen there, it shows variable A, B, C, D, E. So stem length, whether or not you use a collar, how long the neck is, what's the angle of the neck, how offset is the neck from the overall stem. And so each one of these is a different variable that can be changed. And so there are a host of different options of stems, and we have a very large inventory at our hospital. You go into the inventory room, it's just shelves of these different implants. And so at the time of the operation, I'll be doing everything, use the x-ray machine, and we really customize this to you. So, just yesterday it was a size 11 stem, which is 140 millimeters in length, and the offset is either standard or high offset. We used a high offset, and then we increase the neck length, change the different sizes. So there's all these different variables that we do it so that we can re-establish what is the most normal anatomy for each patient. A little bit of the data that I was talking about with that Karai stem, which is the one that I like to use the most, shows 95% of these survived to 12 years. So what that means is that if you did a 100 patients, did a hip replacement on them, and then waited 12 years. 95 of those people have that same stem in, which is pretty good data. And then even more impressive, I just found this as I was preparing for this talk, Journal of Arthroplasty 2018, this group said at 30 years, 93% of their Kurai stems didn't have any problems. That's remarkable. So, great stem, should last a really, really long time. So when we're having those conversations of, man, I'm only 50 years old and my hip is killing me, I need to have my hip replaced. How long is this thing going to last? Well, 93% chance that 30 years from now, or when you're in your 80s, that stem's still going to be going strong. So pretty remarkable data there. And then on the acetabular side, the cup side, I wanted to show this picture. This is a very, very, very high-powered microscope picture on the bottom left there showing the surface of this thing. And I brought one here as well. And so this is what the cup looks like. This is a real-sized one that we put into patients. In the back surface of this is very rough, right? Just like that femoral component, so that the bone grows into it. And so we prepared the pelvis so that this fits, boom, just perfect in there. But you can imagine, so this is a hemisphere, right? A half a sphere. I can put this in a bunch of different positions. I can put it vertical. I can put it horizontal. I can open it. I can close it. I mean, there's so many different ways that you can put this, that having that x-ray at the time of surgery helps you just dial in exact component position. And then finally, the bearing surface. So the bearing surface is the part that actually moves. And the most common bearing surface that we use is a ceramic head. That's that pink ball. And so that actually fits onto the stem. The ball fits onto the stem. And on the cup side, there's a liner that clicks into the cup, and that's the plastic. So the most common one that we use is a ceramic head on a plastic liner. And so in the old days when hips would wear out, is a plastic most commonly that would wear out. It would make little particulate debris that would irritate the hip, and then we'd have to go redo hips. And that's one of the main reasons that I redo hips these days is some of those old plastics have worn out. But good news for patients who are getting hips or thinking about getting hip replacements in the modern plastics are great. They don't wear out the same way that the old ones did. They're lasting longer than we're putting them in there. So that polyethylene wear is not nearly as big of a deal as it used to be. So ceramic head on a polyethylene liner, when they test all these things in the lab and they put them through millions and millions of cycles, that has the best wear characteristics. So that's what I most commonly use. Occasionally we'll use a metal head from time to time. But boy, ceramic on highly cross-linked polyethylene, which is fancy words for the treated plastic, gives you the best chance of that thing lasting a really, really, really long time. And so, just one more study. 15 years out from a hip replacement, over 90% survivorship in this study, and over 90% patient satisfaction. So not only are they lasting, but patients are enjoying them as well. So, summary. Anterior approach, at least in my hands, allows me to get the parts in a better position, allows me to reproducibly put those parts exactly where I want them. It helps my patients to have faster recovery, helps them to get up and get moving sooner. I commonly use a metal or ceramic head on a highly cross-linked polyethylene bearing. I think that's most common in the United States these days, and it's got good evidence to show that it's got the best wear characteristics and will last the longest time. 95% of the time we're using cementless or press fit, where we don't actually cement the parts into the bone. And then, as we showed, excellent long-term results with these hip replacements. Chances are they're going to last a really long time. So that concludes the prepared material that I have for you guys. I appreciate everyone's attention. I hope that this has been educational for you. Again, I look forward to seeing you guys in the office and going over this stuff with you. And you can actually, again, hold these parts in your hands and get a sense for the weight of them. And we can talk about all this stuff in detail in person. And we're going to go over to a live question and answer session now. So again, thank you for your attention.